evening to one and all present here today. I'm really honored to invite you for the webinar on implant dentistry. We have eminent speaker Dr. Ravi Bhayana, certified implantologist and also experienced person with more than 25 years in the field of dentistry. Today, I would like to give a brief note about Dr. Ravi Bhayana in his various commitments towards dental fraternity. He was a member of OI, ICOI, AOI, IAACD, IAP, IIRD, DPFI, and also the former secretary of Indian Dental Association, Ghaziabad branch 2019 and 2020. He has got eminent experience in the field of advanced training in hard and soft tissue regeneration and digital implant dentistry in USA, South Korea, and Thailand. We are so humbled to have you on board, sir. Over to you. You may proceed with the session. Thank you.
Thank you so much, Soumya. Hello, everyone. Good evening. I'm Dr. Ravi Bhayana. I'm practicing implantologist in NCR Ghaziabad. Today, I'm very thankful to Soumya and his team of MedPiper to invite me on this platform and sharing my views and experience of all the years with all you guys. So today, my topic is implant dentistry. So as we all know, implant is the most happening thing nowadays. Implant is basically a biocompatible alloplastic material that is used for surgically placed into small facial tissues and used for anchorage, functional, therapeutic, and or aesthetic purpose. So when we talk about the implants, as we all know, the concept of osseointegration was started by Dr. Brennemark. He was professor at the University of Gothenburg, Sweden. He who invented the threaded implant design made of pure titanium. So he developed basically the concept of osseointegration, and he did various studies on osseointegrations. And the process of osseointegration was in fact an accidental discovery on his part. So he used to do microscopic studies on rabbits, and one fine day he found that when he placed the titanium in the tibia of the rabbit, then was not able to take it out. So that led to the discovery of osseointegration. And he also started with the protocol for fixed mandible prosthesis. And 1982 Toronto conference, he gave the guidelines for implantology. So what is basically osseointegration? The direct contact between living bone and a functionally loaded dental implant surface without interposed soft tissue at the light macroscopic level. And the clinical manifestation of osseointegration is absence of the mobility. So if the implant is not moving in the bone, that means it is osseointegrated in the bone. So let's see what are the main causes of the tooth loss. Why do we implant? The implant basically a restorative procedure, a prosthetic procedure with a surgical component in it, which is mainly used to replace the tooth. So there are many causes of the tooth loss. It can be either root fracture or accidental trauma, caries, periodontitis, parafunctional habits, or maybe even sometimes orthodontic corrections. So these all causes lead to the tooth loss, and for this we need to have something to replace the tooth, which nowadays we are doing with the implant. There are plenty of other options also to replace the missing tooth, but today now we are mainly concentrating on the implant procedures only. One second. Yeah. In 1981, WHO and FDI set a goal for oral health. And as per their goal, the 50% of the people aged 65 plus should be retaining a minimum of 20 functional teeth by the year 2000. But this is far from reached, and it is a very long back study. So we have yet to achieve that goal. Now, what are the various treatment options available with us as far as the tooth loss is concerned? We can give the patient the tooth supported bridge, removal denture, partial dentures. Single tooth replacement can be done with the implant. Implant supported bridge can be given. Then the fixed options are there, removal options are there, removal with the locators are there, and full arch prosthetic rehabilitation is the main. So when you talk about the implant and when we compare with the natural tooth, as we all know, in the natural tooth, we have a cementum, we have periodontal ligament, whereas implant is concerned, we don't have any cementum, any periodontal ligament. So when we talk about the implant designs available with us today, generally there are two types, generic two-piece implant or generic one-piece implant. Mostly we are using two-piece implants with the root form and osseous implants with the abutment connected to that. We can also have options of one-piece implant where we can place the implant in the bone and the part which is connected to the implant, that is the abutment, is one go, so it's one piece. The piece will come out through the mucosa and we'll put the cap over that portion of the implant. So there are various types of implants available with us right from the history. They can be subperiosteal, ramus, endosseous, mucosal, transosseous. Mostly we are using nowadays endosseous root form implants that can be threaded implants. And when we talk about the various implant surfaces, they can be either machined or textured, subtracted or added, or oxidized. Now the gold standard is SLA surface implants or etched implants. SLA means sandblasted, large grid, acid etched implants. This is a small video regarding how the making of the implant process goes. You use the titanium rods and they are milled
and sends the images to a computer for analysis. The computer confirms the dimensions are exactly right. Then the robot collects the implant and places it in a slot in a tray. Once filled with implants, a technician screws a mesh lid on the tray and slides it into a metal basket. This holds them steady for cleaning in a special washing machine known as a vapor. It will serve as a mask to protect the output, to color code the part and indicate the diameter. The ancient Mayans hammered. The implant sparkles in a solution as it undergoes a transformation. Here's the new porous surface magnified by a microscope. A robot transfers the dental implants to another tray. They're now ready for a final cleaning. They go into a tank full of hot, purified water. A generator sends high-frequency sound waves into the water, creating bubbles and waves that gently scrub the implant.
So we saw that how the implant preparation goes and how the company they make the implants. So when we compared the implant and the tooth, as we all know, there is a cementum and there is a periodontal ligament associated with the tooth, whereas the implant, we don't have any blood supply from the cementum or periodontal ligament. Blood supply is mainly from the periodontium. So why would you choose to place the implants in first go? There are various advantages of the implants when we compare with the bridges or when we compare with the bridges or with the dentures. As we all know, the bridge, we have to cut the nascent virgin adjacent teeth to put the bridge, whereas for the implant, we don't have to do that procedure. Bridge tends to have short lives, maybe up to 5 to 10 years. Success rates for the bridge decreases steadily after 10 years. Bridge can sometimes be more economical at first, but in the long run, a dental implant can cost you less. There are various options available with the implants. Dental implants provide a far superior experience compared to the dentures. Implant-supported dentures provide far greater stability and chewing power than conventional dentures. Even dentures that originally fit the patient will help to slip and become uncomfortable after a while due to increasing bone loss. So there are various factors that influences the use of implants. They have like psychological aspects of the tooth loss, aging population, tooth loss related to the age, anatomic consequence of edentulosum, poor performance of the removal processes, and predictable long-term results of the implants. So these all are the causes which have led to the more usage of implants nowadays. Aesthetic is one of the main concern why we are using implant, because that will give you a more natural profile when we talk about the implants in the aesthetic zone. The tooth seems like coming out of the tissues instead of being on the other teeth. As we all know, as we age and we progress, we become older, the sagging starts coming to on our face. Lower third of the face starts to collapse, gradually closer of the distance between the tip of the nose and the chin. These include the excess wrinkles around the mouth, thinning of the lips, and the more pointed chin. Person look a lot more older than his or her age. So basically, sagging is basically because of the bone loss resulting from the missing teeth. The continuous process is called continuous resorption. The survival rate of the implant is almost 97 to 98%. For the implant survival rate for the single crowns is 97%, and for the fixed partial dentures for over 6 years is 93%. There are very decreased contraindication of the implant nowadays because of the advent of the zygoma implants or all on the four techniques and more uh, computer aided guided surgeries. So we have very decreased contraindication. We are able to do the implants in almost each and every case nowadays. So this advancement in the implant designs, bone grafting procedures, analysis of the extensive outcome data have greatly narrowed the use of range of absolute contraindication. So in each and every case, mostly we can do implant nowadays. Maybe in certain cases, the certain extensive procedures are required, but if the patient is willing to go for that to that extent, we can do the implant each and every case. The best option for the edentulous implant for the edentulous patients, dental implants have become a standard treatment option to improve the quality of the life of your patient. Nowadays, as we are following the immediate loading protocols, so treatment time has really reduced, and it's also become more predictable and a safe treatment option. Increased acceptance and decreased of the implant over the years. That is also one of the main cause the patient more and more patients are opting for the implant nowadays. Then we have plenty of plethora of information available to us on the internet. Patient can go check and they get more knowledge and they can really ask about the options we have today. So this is also one of the main causes more and more patients are opting for the implants. So what are the risk factors associated with the implants? Now, when you talk about the drugs, then there are certain drugs which are associated with the contraindication, like few NSAIDs, then few antidepressant drugs like serotonin. And the diabetes is not a absolute contraindication. If we have controlled diabetes within the range of 6 to 7 HB1AC, then we can perform the procedure in a diabetic patient as well. We have to certainly inform the patient beforehand about these things before starting the procedure. Periodontitis and smoking is also not absolute contraindication, but depending on the level of the disease in the patient's mouth and the patient's smoking habit, we may have to certain time alter the implant and inform the patient well in advance. There are various recent advances in implant dentistry today. There are advancements in the diagnostic imaging, recent advancement in the implant design, advances in the implant materials, advances in the commercially available implant systems, software simplifying the treatment planning, advances in implant abutments, implant abutment connection, and there are various new concepts in implant rehabilitation. Now we have a concept nowadays, like all-on-4 concept we are following also. And then the zygoma implants, where the insufficient bone in the posterior maxilla don't allow us to place the conventional implant. We may have to opt for either the all-on-4 implant option or the zygoma implant options. There are various new techniques coming up. Few are tried and few are being tested, like partial extraction therapy, then socket shield technique, osteodensification, all-on-4, all-on-6, zygoma, basal implants. So there are plethora of treatment options available to the dentist and for the patient, and he can choose which suits the patient best. So anyhow, like whenever we plan to place the implant in the patient's mouth, we have to do a certain treatment planning, which is basically a sequential analysis. Now, the planning should include broad and complex set of interwoven factors that we should consider before formulating a treatment plan. There are 3 stages in any treatment planning, like initial consultation with the patient, joint treatment planning, and final treatment considerations. Initial consultation should include all the diagnostic X-rays, OPGs, CBCTs, models, diagnostic casts, and we should be able to tell the patients what are the various possibilities available to him without emphasizing on the possibilities which through which we will be making more money. But we have to really honest with the patient and tell him or her all the options available. And it's a patient right to choose whatever he or she wants to choose. Then the joint treatment planning means we have to think the patient in a totality, not a some. When we think about the implant, we should think about all the various branches which we may have to include during the planning of the for that particular patient. Either it can be orthodontist, either it can be surgeon, either it can be prosthodontist, either it can be periodontist. We have to really make the mouth disease free before starting the procedure. And also we have to really explain the patient what are the various consequences and what are the various additional things which we may have to do while doing the procedures, before doing the procedure, and even after doing the procedures. Final treatment consideration should always be explained to the patients regarding the type of prosthesis which we'll be using, and also if and when the need arises for any complications or any repeat procedures, that should also be told beforehand. We should always take the consent from the patient before starting the procedure and explain each and everything in a written format. That will ease out the things later on, and when the things progresses at later stages, God forbid if any complication arises, that will be really helpful to all of us. So when we talk about the treatment procedures, there are certain protocols which has been laid down. This is one thing called SRA protocol algorithm. This is basically regarding the sequential ridge augmentation procedures. Previously, as we all know, when we always used to talk about the augmentation, it was always about the bone. But sequential ridge augmentation is one protocol which gives a beforehand idea about the soft tissue as well as the hard tissue availability in that particular case in the patient's mouth. So we have to think about the soft tissue also before starting the procedure and hard tissue also before starting the procedure. There are various options available as far as the bone augmentation is concerned, like veneer soft bone graft, onlay bone graft, saddle bone graft, interpositional bone graft, or ridge splitting technique. Depending on the case and the requirement of the patient, we may choose any of these and then proceed with the procedures. As far as this algorithm is concerned, when you talk about a sequential ridge augmentation algorithm, we have to think about keratinized tissue first. We have to see whether the available connective tissue is there to proceed to go ahead with the procedure plan, or we may have to augment the soft tissue first and then we can augment the hard tissue. So in this algorithm, the most importance is given to the soft tissue augmentation. So if we start the case, if we on examination, if we see if this is inadequate soft tissue, then we have to augment the soft tissue first and then go ahead with the case. So if the inadequacy of the soft tissue is less than 2 millimeter, then we can place the implant simultaneously and we can treat the inadequacy in the second stage. And if the inadequacy is more than 2 millimeter, then we may have to think about the augmentation of the soft tissue first, then do the hard tissue augmentation, and later on we can go ahead with the remaining treatment. So this is not a mice slide. This is basically a case showing depicting the free gingival graft, where the free gingival graft has been done after the implant placement, and you can see the result. There is a thick layer of keratinized tissue around the implants once the implant has been osseointegrated. So when we think about the implants, and we have to also think about the restorative materials available and the choice we have in our hand. The choice of the material actually depends on the inter-eye distance available to us. When you talk about the choice of material, so ideally the situation or clinical situation present in the patient mouth should dictate which type of material should be used. Neither the doctor, neither the technician, and neither the patient. In my opinion, the only choice we can have is only through the assessing the available clinical situation. If the inter-eye distance is around 8 to 10 millimeter, then choice of material is obviously PFM or zirconia. And if the inter-eye distance is 10 to 14 millimeter, then the PFM with the pink ceramic, that is FP2 type of processes. And if the inter-eye distance is more than 18 millimeter, then the choice of material is overdenture, that is FP3 type of processes. And now, as far as the timing and placement of the implant placement is concerned, it has been classified by Chen and Guzer in 2008, type 1, type 2, type 3, and type 4 type of implants. Immediate placement. Type 1 immediate placement is when an extraction socket with no healing bone or soft tissue has been occurred, like post-extraction immediate placement. The early placement with soft tissue healing, this is type 2, typically 4 to 8 weeks of healing. A post-extraction site with healed soft tissues but without significant bone healing. Type 3 is the early placement with partial bone healing, typically 12 to 16 weeks of healing. A post-extraction site with healed soft tissues and with significant bone healing. Type 4 is a late placement, more than 6 months of healing, and the desired clinical outcome is a fully healed socket. During the third ITI consensus conference, they have given the consensus about the type of loading protocols, like immediate loading, early loading, conventional loading, and delayed loading. Immediate loading is when we place the implant and load the implant with the opposing dentition, and the conclusion and with the opposing dentition within 48 hours of implant placement. Early loading is when the restoration is being loaded, the procedure is being loaded after 48 hours but less than 3 months. Conventional loading is when the second procedure is carried out after a period of around 3 to 6 months, and delayed loading is when the procedure is carried out more than 6 months. And immediate restoration is also been described. It has been described as a restoration which is inserted within 48 hours of implant placement, but not in occlusion with the opposing dentition. That means we are giving the patients a temporary teeth in the anterior zone, and we are keeping that particular restoration out of occlusion. Now, depending on the type of processes, there is a classification which has been laid down. Like it's called FP1, FP2, and FP3. So there are 3 types of fixed processes, and RP4 and RP5, there are 2 types of removal processes. So FP1 is basically when you only replace the crown and there is no soft tissue replacement. FP2 means when we replaces the crown, a small portion of the root also. In that case, the crown contour appears normal in the occlusal half, but it is either elongated or hyper-contoured in the gingival half. And the fixed process is number 3, FP3, which replaces the missing crowns and the gingival color and the portion of the edentulous site. Now, depending on as we already discussed, depending on the type of the amount of resorption in the patient mouth and the availability of the inter-eye distance, we can choose which processes we have to give, either FP1, FP2, or FP3. RP4 is a removable type of processes, which is mainly an overdenture and completely supported by the implants. And RP5 is an overdenture which is supported by both soft tissue and the implant. So when you think about the implant in the anterior aesthetic zones like post-extraction, immediate placement, there are 5 basic diagnostic keys which we should think about, like the relative tooth position, form of the periodontium, biotype of the periodontium, tooth shape, and position of the osseous crest. Because as you all know, the topic of implant dentistry is such vast topic, and to cover each and everything is not possible in this 1 hour time. So I have just prepared the slides to give you some idea what we are talking about, and then once this theory part and discussion is over, then we talk about some of my few clinical cases which I've chosen on depending on the various procedures we have done, and we will discuss more about the things, clinical thing, as we talk about, well, as we discuss the clinical cases. So to start with my clinical cases, I've chosen this particular case. This is a case where there was congenitally missing upper right lateral incisor. The spaces were there in the anterior between the upper anteriors and the lower anteriors. So our treatment plan was to first close the gaps by doing the orthodontic treatment, create more space which is required for the upper lateral incisor, and then place the implant and give the patient the normal tooth. So first we completed the orthodontic treatment, created the space for the lateral incisor. This is the X-ray after the completion of the orthodontic treatment. So once the orthodontic treatment is completed, so we decided to go ahead with as per our planned treatment of the implant placement. So in this case, we used the acrylic tooth, which served both as a guide and also as a means to maintain the space which we have gained during the time when the implant is getting healed in the patient's mouth. So this is how we use this acrylic tip for the purpose of
third prostrate சொல்லுங்க அப்பதான் தெரியும் நான் வந்து சொல்லி நான் வந்து இப்படியே பார்த்துட்டு இருக்கேன்
I think there's some disturbance moral support Soumya.
அவங்க இந்த சேர்ல உட்கார்ந்துப்பாங்க
Soumya, can you hear me? This slight disturbance which is coming up. Yes, it's okay. So we started with our planned treatment, placing the implant in the anterior zone. As we know, this was a delayed implant placement procedure, and we were really a little worried about the creation of the interdental papilla. So we placed the implant a little bit more submerged. This is an X-ray after placing the implant. After a few months, when the site got healed, there is a beautiful stippled gingiva you can see. So we use the same tooth to maintain the distance we have, to maintain the space we have created for the lateral incisor. We took the shade, took the impression, and the lab people have prepared a very nice PFM crown. So this is how the patient looks when we fix the crown and move the braces. She was really happy with the outcome, and this is how the tooth looked like when the treatment got completed. We gave the fixed retention in the upper arch and in the lower arch. And nowadays we are recommending to go for the combination of the fixed appliance as well as the removal Essex retainer, so that fixed retention can hold the upper anteriors and the the removable Essex retainer can hold the posterior segment also. This is the picture of the happy patient. This is the second case which we'll discuss today. So as you can see, there's a little collapse on the facial aspect of the bone. There is a buccopalatal collapse of the bone because of the long-standing extraction. We opened the site. We tried to place the implant in 3D as per 3D position of the implant protocols, medial-distally, cervico-opically, and buccolingually. While doing so, we can see there were the few of the threads of the implant which were exposed after placing the implant in 3D position. We used a mixture of autograft and the xenograft to cover the implant and cover the implant with the resorbable biological membrane, collagen membrane. We suture it and we try to pull the lip to see to check the passive suturing. Once the implant got healed, we took the impression, and this is how the tooth looked like once we finished the job. This is a slight black triangle visible on both the mesial side more, and little bit on the little bit on the distal side also, but that was acceptable to the patient, and we tried our best to make the patient happy. So there's another option for the mandibular full arch cases, the mandibular implant overdentures. As we all know, implant overdentures comes under the category of removal RP5 category. These are basically implant retained tissue spotted processes. To achieve good results with the implant overdenture, we should always have a stable, well-fitting complete denture first. Only then we can give the patient a well-fitting implant spotted overdenture. So in some cases, we may have to make a new denture which should be stable and well-fitted. Depending on the implant location and number, we can have plenty of options available to us. There are options available also as far as the attachment are concerned. They can be either ball attachments, rubber O-rings, or metal housings, ball attachment with the clips, locators, or magnets. Locators we generally use when there is a divergence of the implants, that when the divergence is more than 15 degree, then we can use locators, but the divergence should not be more than 35 to 40 degree. The best result or retention which we can get either with the locators or with the bar attachment with the clips. O-rings give little less retention as compared to the bar attachment with the clips and the locators. So you can see here we have used the locators. We given the patient 3 implants. Once the implants are osseointegrated in the bone, we took the impression, that is a pickup impression. We fixed the locator in the patient's mouth in the same sitting only. Once we got the denture, this is how we pick the locators, and they look like this in the lower denture. And this is a new upper lower denture with the locators. Other option is mandibular implant overdentures with bar and clip. So this is how the patient came to us with the old denture. We first placed the implant and lined the lower denture with the soft liner, and patient kept on using that lower denture relined with the soft liner for a few months. Once the implant are osseointegrated in the bone, we took the impression, sent it to the lab, and the lab people have prepared a nice bar and clip attachment with little bit extensions on both the sides. The extension provided the added retention, and patient was very happy with his new denture. This is how the upper and lower denture looks like. Is a happy patient. Now, this was a case which I would like to discuss a little bit in detail with you guys. This was a patient who came to us with the broken and chipped off upper anterior. Patient brought a chipped off fragment with him and asked me to fix that broken chip of enamel. So we saw the case. We could analyze. There is a lot of challenges if the patient agrees to the treatment. The bite was really collapsed. There was no posterior teeth to support the bite. There is a palatal thinning of the upper anteriors, adhesion of the lower anteriors, broken enamel chip, and there's a over extrusion of the premolars and the canines on both the side and the molars on the left side. This is how patient looked like before starting the treatment. These are all pre-op photographs. You can clearly see the palatal thinning of the enamel on the upper anteriors and over the lower incisal edge of the lower anteriors, canines. Posteriors are missing, so that led to the collapse of the whole bite. So to start with the case and gain some confidence from the patient, we fixed that broken enamel piece, chipped off tooth piece with the simple composite and explain the treatment to the patient, why it is happening and how, if he doesn't care at this point of time, the more challenges he will face and it will be more difficult for him to undergo the treatment. So he listened to us and eventually he told us to start with the treatment. We advised the patient to get one OPG done. You can see the total collapse of the bite and total collapse, supra eruptions of the molars of on the left segment, supra eruption of the molars on the right segment, the supra eruptions of the lower premolar also, broken root pieces, wearing of the lower incisal edges. So to formulate the treatment plan for this case, our challenges were to restore the lost vertical dimensions to achieve the optimum aesthetics and function, immediate implant placement, indirect sinus lift and submerged approach for the posterior implants as per the SRI protocols, restoration of the natural remaining teeth with minimal invasive dentistry, Emax palatal veneers in the upper anteriors and incisal level veneers in the lower anteriors, endodontic intervention and prosthetic procedures, including crown and bridge in second quadrants. So this was the treatment plan for him. We also advise him to go for implant on the upper left quadrant, 2-4 side, but the patient refused to go for that. So we planned for 3 implants on the upper right side, 2 implants on the lower right side, and 2 implants on the lower left side, posterior side. This was the treatment plan for the upper arch, and this was the treatment plan for the lower arch. To start with, we place the implant in the upper right segment first, posterior segment first. We first place the implant in the region of 2-5. That give us some idea how far we are there from the sinus. We have to do the indirect sinus lift in the region of 1-6. And once we are through with these 2 implants, we extracted the root piece of 1-4 and placed the implant in 1-4 region. So these all done. So this is basically the planning of the treatment, and this is how we executed the treatment. Meanwhile, the implants were integrating in the bone. We did the root canals of the upper lateral incisors and the canines. Then we placed the implant on the lower right side, 2 implants on the lower posteriors, 5-6 4-6 and 4-5 and 4-6 region. So after a period of around 1.5 to 2 months, we decided to go ahead with placement of the implants on the lower left side posterior region, the molar and molar region. Once the implants were osseointegrated, we decided to go ahead with the remaining treatment. We took the Facebook records. We take the CR with the help of leaf gauge, and then at that moment of time we could analyze how much space we need for the placement of the upper teeth and for the placement of the lower teeth, and to create a balanced occlusion on both the sides with the proper occlusal table. So as you can see in this photograph, we raised the bite with the help of normal composite for the time being. So we repaired the incisal edges of the lower anteriors. We placed the composite on the palatal aspect of the upper anteriors, and that's how we able to raise the bite and gain some interarch space for the restoration of the upper posteriors and upper premolar. The lower implants got integrated very well, or she integrated very well. We took the impression, we took the zig trial, and this is how the lab people, they have prepared and sent the bridge on the upper second quadrant, and the implants supported screw retained PFM crowns on the lower posteriors and the zirconia crown on the lower canine. So this is how the patient look once we fix the upper teeth on the upper left side and teeth on the lower left side. So once we have established the occlusion, then the things were easy to fall on. Then the remaining case was pretty easy to complete. This is how the implants looks in the lower arch and the bridge in the upper arch. Meantime, the implant has been taken well by the patient's body, and they have been like integrated very well. So we took the measurements, we took the impressions on the right side, upper right side and the lower right side, and we took the zig trial, and the lab people have prepared a very nice screw retained PFM bridge on the upper and the lower arch. So this is how the occlusion of the patient looks like once we completed the treatment on the upper on both the sides, right side and the left side. This is the OPG which patient shared with us once the treatment is completed. As you can all see and appreciate, all the implants are well osseointegrated in the bone. The patient is maintaining the occlusion well. Our initial plan was to place the palatal veneers on the upper anteriors and on the labial and incisal edge of the lower anteriors. But somehow, as we all know, we live in India, and once the patient was happy and was doing fine, he kept on avoiding the remaining treatment. So my apologies, I don't have the post-operative final photographs with me. So this is how we started, and this is how we ended. I would like to share with you guys, there's another case. This is FP3 processes. This is a case who initially came to us around 10 to 12 years back. He was having his old PFM bridges in his mouth. That bridge was like single unit for the whole upper arch. The patient was having difficulty in the mastication. There was sensitivity to the hot and cold. We took the X-ray, and this is the time when CBCT was just starting actually. It was just starting to gain the momentum. So, and in those days, we were not doing the post-extraction immediate implant placement. So first we remove the whole bridge and find out if we cannot restore the remaining dentition. So we explained that to the patient, and patient is a well-known, renowned builder of our area, NCR area, and he's very much socially active. So our main challenge was to give him minimum trouble and give him the processes he wants for his active social life. So we decided to go ahead with the guided implant surgeries in this case. We used the patient old denture, which we gave after the extraction, and we used that old denture with the radiographic markers to plan this case for the CBCT and guided surgery. The bone was pretty good in the posterior region, in the premolar region, but not so good in the upper anterior region. So this is how we planned the case on CBCT with the radiographic markers. And we went ahead with preparation of the surgical guide for this case to make this case good for the guided implant surgeries. As you can see, we had to use a tilted implant on the upper right side and on the upper left side. The tilting was more on the left side as compared to the tilting and more on the right side as compared to the left side. The left side implant was more or less straight, but the angulation of the implant in the anterior region was extreme. So we decided to go ahead with the guided implant surgery for this case. During those days, the guided implant surgery was also just started during those days. So we were not very much confident about the accuracy of the guide we got from the lab. So instead of going for the tissue spotted, we decided to go ahead with the bone spotted guide, and guide which can be fitted at the bone level. So to start with, this is the patients. If you see the upper arch, you can see there's a lot of bone available, but in reality, there was the bone was pretty less in the anterior segment, and there's lot of thick band of keratinized tissue, which was the advantage in this case. So we raised the full thickness flap of the whole arch in one go. We tied the upper palatal tissue, and we tried the bone level guided implant surgery stunt. We checked the accuracy of the guide first, and once we were satisfied with the accuracy of the guide, we fixed the guide with the screws. You can see these are the channels for fixation of the guide, channel for the screws which we use to fix the guide in the bone before starting the procedure. And these are the channels which we use to prepare the osteotomies. So as we also new to this procedure at that point of time, we were not very much confident about the accuracy of the guide. And being from old school of thought, we first use the guide only for the first two initial drill, so that we can establish the pathway and angulation of osteotomy. After doing that, we removed the guide and went ahead with the freehand implant placement. Because the bone was less in the anterior region, we had to use the expansion screws also to expand the bone, and we also did the veneer graft in the upper anterior zone. We went ahead and placed the implants in all the areas. We opted for 8 implants in the upper arch because, as you can see, there were 2 molars present on the lower arch on both the sides to compensate for the excessive forces which may occur during his lifetime. So to be on the cautious side, we placed the 8 implants in the upper arch. All the implants taken up very well by the patient mouth. You can see the well keratinized tissue all over the implants. Now this implant, which was tilted, we have to use the multi-unit abutment. These are all our biooriginal implants. We took the open tray impression, sent it to the lab for the zig trial. But as you can see, we have not splinted the open tray copings. So this led to a little bit discrepancy while taking the impression. And when we received the zig trial from the lab, it was not fitting very well. So we had to repeat the zig trial. We make customized open tray, and we use that tray for the pick of impression of the zig trial. And once the zig trial was okay, the lab people, they have prepared a framework, comb cobalt framework, milk comb cobalt framework, and over that they given us the teeth setting trial. We checked that trial in the patient's mouth, and patient was very happy seeing his new teeth, fixed new teeth. Once he has given the consent and he was happy with the aesthetic outcome of his new teeth, then we went ahead and got it acrylized. As you can see, there's a opening of the screw is coming lably on both the upper anteriors because of the extreme angulation of the patient's bone. We closed it with that pink composite and the white composite. This is how the picture looked like once we fit the appliance in the patient's mouth. And patient is still carrying the appliance very nicely and is happy with his teeth. Now we opted for FP3 processes in this case because there was a lot of resorption was there and the interarch distance was very more. Even though we extracted the teeth, but still we had a lot of interarch distance. It was more than 20 millimeter, and patient really want to have the teeth which he can show while speaking and while smiling, because he has so much of active social life. So that's why we went ahead and give him the FP3 processes. Now this is another case. This is full mouth rehabilitation FP2 processes. This is a very long case actually. We did the lot of treatment options we use in this case, like post-extraction, immediate placement, sinus lifts, and also this patient, the challenge with this patient was she always wanted to have teeth in her mouth. So in this case, we have to do the sequential implant placement, and we have to maintain certain teeth in a patient mouth so that we can use those teeth for the temporaries. And while my implant are getting osseointegrated, we have to use the natural teeth for giving the temporary teeth. But since the time is very less, so I have just put it on like few pictures of this case. This is after we done with the lower implants. We got the trial, and this is how the appliance looked like in the patient's mouth. This is how it looks like once we completed the lower arch. And once the lower arch is completed, she started having some issues few years down the line in the upper arch also. So eventually we had to do the upper arch one by one. And this is how the case looked like once we completed the whole treatment in both the upper and lower arches. Because this is a very long case, so I've just put it the few slides in this presentation to share with you guys. This is a case which I would like to share with you. This was one of the patient referred to me by my fellow clinician in Ghaziabad. The patient came to us like this. He was wearing the fixed bridge in his upper arch, implant being placed in the upper arch and both the lower arch, while the lower arch has been restored with the PFM processes. He was having the temporary bridge in the upper arch. Even though the lower implants were also not placed well in the position, the patient was only interested in getting his upper arch corrected. So when we remove the temporary bridge, this is how the situation looked like. As you can see, there is pretty less of keratinized gingiva around the tissues. The angulation of the implant is also not in optimum position. We explained the whole thing to the patient. We told him we have two options. Either we can take the implant out and put the implant in the new position, ideal 3D position. But the patient refused to undergo for that new implant procedure. So we explained we may have to do certain compromises and the patient may have to accept certain compromises for his treatment. After getting his consent, we told him to get the CBCT done. So as you can see in the CBCT, there are plenty of bone loss in the labial surface of the implant, labial aspect of the implant. The angulation of the implant is also extreme. After explaining to the patient, we opened the area, we checked the osseointegration of the implants in the patient mouth. Once we were satisfied that they are not moving and they are not going to come out easily, we did the remaining treatment. We thoroughly cleaned the area, did the curettage, and covered the implant surfaces with a mixture of autologous bone and the xenobone. Here we have used minerals. Here we have also used the PRF. We cut the PRF and we mixed that PRF with the graft, and we cover the graft with the PRF membrane and suture it back. So this is how it looked like after waiting period of around 6 months. Nothing can be changed much about the angulation of the implant, but you can see the band of thick keratinized tissue around the implant. So these were the external hex implants. We took the impression and got the milled abutment from the labs. We did the try-in PFM metal try-in, and this is how we finished the case. You can see this is FP2 case, or you can say even FP3 case. There are the long teeth with the component of pink gingiva. The only savior in this case, because the patient had a very low lip line, so the border and the junction of implant and the tissues were not visible, and he was happy. So are the implants the only replacement possible for only means for replace the teeth? On the basis of the survival rates, it appears that more than 95% of the dental implants and endodontic teeth, they remain functional over time. The success of the implants depends on the interrelationship of the various components like biocompatibility, macro and micro surface of the implant, health of the bone bed or traumatic technique, undisturbed healing phase, and conducive processes. Implant survival rates do not exceed those of compromised but adequately treated and maintained teeth, supporting the notion that the decision to extract a tooth and place a dental implant should be made cautiously. Furthermore, a tooth can be extracted and replaced at any time. However, extraction is a definite and irreversible procedure. The treatment planning should involve the long-term probability of the success for any chosen treatment modality. So, preserve the teeth and reduce the risk before replacing a tooth with an implant. So, consent and complications. So, we should also it's our duty to make the patient aware about the possible complications, and we should always take the consent first from the patient before starting the procedure. We should explain to the patient regarding the possibility of the failure, possibility of the nerve damage, possibility of swallowing the things during the procedures, fracture of the crown, screw loosening, peri-implantitis, recession, infection, pain, swelling, bleeding. So these all are complications which we should make the patient a little aware, so that we should be prepared for any eventual upcoming things. A high implant survival rate has been reported with the following side effects. As we all know, when the patient ages and the implant is in the patient mouth for a longer period of time, we may experience certain complications also during the patient lifetime, like increasing infraocclusion of the implant supported crown, marginal bone loss, recession, and discoloring of the labial mucosa. So to check and see whether there in the literature was the evidence of any protocols, there is a proper information triangle, like uninformed and filtered information should be think of. Now there is a beautiful article by Curran and Herrera regarding the implant therapy and 40 years of experience. So they have given certain changes to the implant protocols which were used previously and which has been used now. So there, as per the original protocol, it was about only the fully edentulous patients, which was a strict inclusion criteria. But present protocol is all type of indications and rare exclusion criteria. Minimal jaw bone width was of 7 to 8 millimeter. Now we can do the implant placement in any case with the help of GBR for augmentation. And a minimum 4 to 6 months healing period was there after the tooth extraction. But nowadays we are talking about the immediate implant placements. Initially, protocol was all about 2-stage surgeries. Nowadays, it's all about 1-stage surgery. Previously, they were doing the submerged healing for 3 to 6 months. Now it's non-submerged healing. There was no denture immediately was given after the implant insertion, and now we are talking about the immediate loading. Only specialists were doing the implants previously, but nowadays general dentists are doing. No surgical guides have been used. Guided implant placement we are using nowadays. Pre-surgical atropine was used to reduce the salivary flow, but no atropine are used nowadays. So when you talk about the implant placement, we have to give patient the certain choices. If she or she doesn't agree for the implant placement, then we have precision attachments at our hand. then the fiber supported bridge we have at our hand. We should respect the patient opinion and the patient judgment, whether she or she want to opt for the implant therapy or not. This is the fiber supported bridge by GC, Everstick Fibers. We have used the Everstick 3G GC fibers in this case. The patient is happy with the outcome. So today, more than 240 million people which are partially or completely edentulous in the whole world. And 69% of the adults aged between 35 to 44 years, they have lost at least one permanent tooth. And 26% of the adults over the age of 74, they will lost all their permanent teeth. So the options are many, so are the opportunities are also many. So India is the basically hub for the medical tourism nowadays. Top destinations for the medical and dental tourism are Thailand, Mexico, India, Malaysia, Brazil, Turkey. So the destinations for the world. But at the same time, we have to remember that the survival of the implants placed by inexperienced practitioner was 73%, as compared with the placement of the implant by the experienced dentist is 95%. So trained professionals are the need for the day. We have to keep upgrading ourselves. We have to keep educating ourselves. As we all know, the education and the learning is a never-ending procedure, never-ending process. Where we are with few of our colleagues attending the various conferences, meeting all the stalwarts of the industries during various implant symposiums. In 2020, we had opportunity to visit Dr. Maurice Lama's center at Atlanta. It was a very good learning experience for all of us. So in the last, I just want to say the dental implants in the future is not near, it's already here. So here I complete my presentation, and I would again like to thank Ms. Soumya and his team of MedPiper for inviting me on this platform and giving me the opportunity to share my experience and my cases with all of you. Hope you guys must have learned something and must have taken some take-home messages at least. Thank you for your time. Thank you very much.
Thank you, doctor. We have a question in Q&A. Would you like to look into it?
Sure, sure. I'm not able to see. Okay, there's one question from the Kalash Gupta. How much time does an implant take to get osseointegrated? So generally it takes 3 months. In the lower arch, we generally wait for 3 months for the implant to get osseointegrated. And in the upper arch, because the bone is softer there, so sometimes we have to wait much more as compared with the lower implant placement. In the upper arch, we generally wait for 4 months. But if the site is grafted, and the grafted site, ideally we should wait for more than 4 months. Ideally, the waiting period is 6 months in the grafted site area. Hope I have answered the question.
Thank you, doctor. And doctor, could you just brief us maybe a couple of courses where we have a good number of medical students, dental students have joined for the webinar. So they wanted to know like courses that they can choose during their studies where they have to do their specialty.
I will share my information with you guys shortly, and soon we are also planning to start our implant course. And basically, depending on the location, the student can choose, because for any implant course, generally lasts for 6 to 9 months, and student may have to travel to the destination. If you are okay with traveling to the NCR area, then we are more than happy to help them out. Otherwise, depending on their location, we can guide them, and for that purpose, they can contact me anytime.
Doctor, when you meet patients whom you are doing the implant surgery or discussion, What are the three basic things that you will tell your patients about doing implants?
First and foremost, we like to listen first what the patient wants exactly, because before without knowing what the patient needs, we don't suggest anything to them. So we first listen carefully to them, then we analyze the case, we plan the case, we give the as I said, first we do the initial consultation, then we do the team planning, and then we give the final outcome of our planning to the patient. So as far as mostly the patient asks for the life of the implant, and we tell them the success rate of the implant is 97 to 98%. And for any implant to be successful, it has to serve the patient for at least 10 years. So any implant which is serving the patient for 10 years, then it only is considered as a successful implant. So this is one of the most questions that what the patient asks. Second question comes about the pain during the procedures and the discomfort they might face during the procedure and after the procedure also. So we make it sure that the procedure of the implant in patient mouth should go peacefully without pain, and only the oral painkillers, those are mainly required after the treatment. There are certain areas where sometimes we have to explain the patient about the extensive graft procedures, because each and every case is different, and that's how the thing goes.
Thank you, doctor. The next question is dental implant painful?
As I told you already, a dental implant is not painful at all. We are doing the surgeries in our own clinic under local anesthesia only. No general anesthesia is required for the procedure. And after the procedure, the patient has been told to only take oral painkillers for 1 or 2 days. The discomfort is like as any other surgical dental procedures like extraction or impaction. So we can say that there is nothing much difference is there between any other surgical implant procedure or the implant surgical procedure or the implant procedure. So it's not painful at all.
Thank you, doctor. The next question is regarding the costing part. Would you like to highlight a couple of the costing plans when we go for a dental implant, maybe from the basics to higher end? Would you like to highlight on this?
Basically, as far as the cost of the implant is concerned, that vary from charges varies from doctor to doctor, also clinician to clinician, and also depending on the type of implant which the clinician is using. So, and also varies from city to city. So the range is very vast. It can start either anything from 15,000 and it can go anything up till 80,000, 90,000. So that depends what's the various requirement of the patient, depending on the type of processes we are giving, type of the implant material we are using, and type of graft materials we are using. The range is very vast. But nowadays, I can assure that whoever is getting the implant done, they won't be disappointed because of the economical reason, because a lot of choices are available nowadays, both for the clinician also, for the doctors also, and for the patients also, as far as the type of implants are concerned.
Thank you, doctor. The next question is, can a regular dentist do a bone graft?
Of course, anybody can do the bone graft, but to each and every procedure, there is always a learning curve. So my recommendation is that before doing the procedures which the doctors are not comfortable, they should get first-hand training, get the hands-on done. They can go and visit their senior seasoned practitioners who can help them out. They can learn from them. They can do for various courses, and slowly and slowly they'll get a hang of it, and then they'll start doing their procedure on their own.
Thank you, Doctor. I think we have taken up all the questions regarding the implant industry. So once again, on behalf of MedPiper Technologies, JournoMed, we would like to thank you, Dr. Ravi Bhayana, for spending your time along with us in detailing the implant procedures and also a couple of scientific aspects around implant industry, maybe from costing to types of implants, procedures, and what we should know about the implants, even for the dental students and also surgeons. Thank you so much, Doctor. Thank you so much for joining us today. And thank you everyone who have joined us today for the webinar on implant industry. We'll be back with new topic around implant and also AMSI. Thank you so much. Have a good day.